Once you hit your exposure button, you apply the kVp and the potential difference across the X-ray tube. You get kinetic energy in the electrons traveling across the tube and creation of X-rays. At that point, you have mass. Mass is just the number of electrons conducted through the anode. And if you remember back from last semester, the only gauge that is in the high voltage side is the mA meter. And the reason for that is because you'll recall that we've got two different circuits. We've got the mA circuit, or the filament circuit, and then we've got the high voltage circuit going into the X-ray tube. So we set our mA on the filament circuit side, but we have to gauge and measure how many amps actually travel through the high voltage section. So the mA meter is wired into the center of the secondary side of the high voltage transformer to measure the actual current that comes through the tube. So it's the number of electrons conducted through the anode, and that directly controls the number of X-ray photons that we create. And by direct, I mean if you double your mass, you double the number of electrons, that doubles the number of X-ray photons that you create. So it controls directly the radiation quantity because it controls the tube current. And we call that beam intensity, and it directly controls the exposure to the patient and to the image receptor. So radiographic exposure and patient exposure both. Most of the time we use mass for technique compensation. Again, unless we want to change the differential absorption, and that involves either because we've got a change in ZEF number, Z effective or effective atomic number of the structure, and that only occurs when we either decrease the density or increase the density, relative density of the organ system. So we introduce contrast. Be it positive contrast, negative contrast, or we add bony tissue where there was minimal bony tissue before. So examples include pathology that increases tissue density. Those are called additive conditions. So if you think about what kVp does, whenever you increase kVp, you get an increase in penetration, you get an increase in penetrated scatter, and that scatter reduces contrast on the image. Also, what you get is an increase in penetration and decrease in differential absorption, which also decreases your contrast. So if you're shooting through tissue that has a low atomic number, like let's say air with a little bit of soft tissue in the lungs, and then you introduce a lot of fluid like a pleural effusion, then you might have a tendency to think, well, I need to increase my kVp, but consider what it is kVp does in fluid. Fluid type tissues create more scatter radiation than air or bony tissue. So you don't want to increase your kVp, even though you've got an increase in relative ZEF number. Fluid is much more dense than air is, or at least the appearance of it is radiographically. But you don't want to increase your kVp because you increase scatter radiation, which degrades your image. So you would increase mass. Pathology that decreases tissue density is called destructive. So you got additive conditions, you got destructive conditions. Additive conditions add tissue density, relative tissue density, even if you don't want it to be there. Pleural effusion would be an example of an additive condition. It's not a good condition, but it adds tissue density. Destructive conditions would be conditions where we reduce tissue density. So most of the time your changes are going to be 30 to 50% change in mass, and that can be an increase or a decrease. So again, your pleural effusion, you may have to increase your mass by as much as 50%. If you've got a pneumothorax or something that is a different destructive condition like I don't know, you got a emphysema, then you might have to decrease your mass by 30 to 50%. It is also what we want to use to compensate for distance changes. Be those distance changes in OID. So if we've got an increase in OID, and we usually call that an air gap, what we have is scatter radiation that misses the image receptor. And that's a good thing. So if you increase your KVP to compensate for that, then you create more scatter radiation to strike the image receptor. So you defeat the purpose of using the air gap by increasing KVP. So you don't want to increase KVP if you utilize the air gap. You want to increase your mass to compensate for that. Same thing if you use a grid. And we'll talk about grids later in the semester. But if you introduce a grid, grids absorb a lot of scatter radiation. And with that absorption of scatter radiation, you're going to lose some radiographic exposure. So you need to reintroduce that exposure. If you increase your KVP, you just create more scatter radiation again. So you want to increase your mass. But back to distance. SID follows the inverse square law. So if we increase our distance, then our exposure to the image receptor would decrease. So if we go from 40 inches to 72 inches, then we would need to increase our technique by a factor of 3.24. You remember from last semester we talked about the inverse square law and the direct square law. Inverse square law tells us how much of a change that we have in exposure with changes in distance. So if you double your distance, it's the inverse square law, you double your distance, your intensity changes by the square of the change in distance. So your change in distance was a factor of 2. A square of 2 is 4. So if you changed your distance from 40 inches to 80 inches, then the amount of radiation exposure on the image receptor would decrease by a factor of 4, and that's because of the divergence of the central ray. Excuse me. If you change from 40 to 72 inches, the same thing happens, but it's not quite a double, so your change in intensity is not going to be quite 4. It's going to be 3.24. So you need to make a change to your exposure in the same quantity or the same magnitude. You go from 40 inches to 72 inches, you need to increase your mass by a factor of 3.24. You go from 72 inches to 40 inches, you need to decrease your mass by a factor of 3.24. So compensation for body habitus, again, is typically going to be mass, because if you change from, let's say, somebody who's asthenic to hypersthenic, then what you're going to see is a change in mainly soft tissue. And again, soft tissue is more like fluid type tissue. And as we discussed with the pleural effusion, with the more fluid we have, the more scatter radiation we create, the more scatter radiation we create, the less contrast we're going to have. So you want to compensate for body habitus with, again, mass. Compensation for grid use we already talked about, and that's going to be mass. Now, if we have some hypotheticals, then we might mix some mass and some KVP for adjustment as well. Let's say, for example, you have a situation where you've got a patient who is pregnant. The first patient of the day that you made an exposure on was of a, sthenic type body habitus, and you had a good technique for that. Your next patient that came in more closely represented a hypersthenic because maybe they were third trimester pregnant, and you need to make an exposure on that. Well, would you increase mass or would you increase KVP? Well, even though it's not ideal, you might increase KVP. So in an example like that, on a test question, you might consider, or what you need to pay attention to rather, would be the indicators that you need to decrease patient exposure. So dose needs to be decreased. And what kind of populations do we want to decrease dose in? Young patients, pregnant patients. So there are exceptions to every rule. mAs is more commonly our technical factor of choice for technique compensation, but sometimes it is appropriate to change KVP. So what are the effects of changing mAs on the image, and what are the indicators that we've got adequate or overexposure or underexposure? And most commonly what we're going to look at is the index number, and that's going to be our indication of whether or not we've got an appropriate mAs. And I understand that index numbers can be a little bit arbitrary and specific to certain exams, so you need to understand what is an acceptable exposure index number for each exam on your particular system. And whenever you rotate from your current clinical site to a different clinical site, what you may find is that some of the equipment vendors have totally different index numbers. Some of them use a system that maybe a range of 200 to 400 would be normal and indicative of good exposures. And some other places may have a system of 1 through 3 or 1 through 4 to indicate that they've got, whatever the exposure index number is would fall within that range from 1 to 4. So when you make an exposure, what you create is what they call a histogram. And a histogram is just a range of exposures on your image receptor that are representative of the tissue that you penetrated. So you can look up a histogram in your textbook, and what you'll just see is a bunch of lines that just don't make a whole lot of sense to you. You can't really get any kind of information off of what the histogram looks like. But stored inside of your computer is a histogram that is representative of an ideal image of that particular image type. And what I mean by that is that when a hospital or a clinic gets a new set of equipment, maybe a new DR room, then what's going to happen is a radiologist, maybe a couple of radiologists, maybe a technologist or two, will sit down in front of that computer with the applications person from the vendor from which they bought the equipment, and they're going to look at a lot of x-rays, and each one of those x-rays is going to have its own histogram attached to it. So the doc looks at these images. He looks at image 1 and he says, okay, that's not good, the contrast is too low, so they'll show him another one, higher contrast, and maybe it's a hand. He says, okay, that one's perfect. So they save that one. That one becomes the histogram for which every single hand x-ray is compared against and adjusted to try to make it look just like that hand x-ray. That stored histogram is what we call a lookup table. And whenever you make an exposure and you use slightly too much or too little radiation, your index number is going to be off. It's not going to be perfect, but your computer system can still make your histogram look like the lookup table, so it corrects for minor mistakes. If you use a femur technique on a finger, your computer's probably not going to be able to completely compensate for that. So it can corrects for minor mistakes, not major mistakes. In that way, contrast may be lost in extreme over or underexposure. We tend to think of KVP as being a controller of contrast, and according to the registry, it still does affect contrast. However, mAs can also, in a digital world, affect contrast as well. So if you greatly overexpose, then you flood that image receptor with so much information that it can't really differentiate between tissue types, and you lose contrast. Likewise, if you greatly underexpose, the same thing happens. You don't have enough signal to the computer system that it can make sense out of what you did. So there's an old saying for computer systems and electronics, and that is that if you feed something garbage, then what you get back out of it is garbage as well. So it's garbage in equals garbage out. So you have to give the computer something that it can make sense of before it can give you a good image back. You can't give it garbage and expect to get something good back out of it. You have to at least be close in your technique in order for it to really make you a good image. Quantum model is going to be specific to underexposure, though. Quantum model just means quantum is a technical term for a quantity of energy. So if you don't have enough energy to the image receptor, you get this freckly looking appearance to it, and that is quantum model. Model means speckly. Quantum means quantity, basically, quantity of energy. And if you don't have a high enough quantity of energy, you get that speckly appearance. So it's a speckly appearance because of inadequate quantum, is quantum model. So it may appear on the image if you have inadequate mAs. Which aspect of mAs do you change? Well, it depends, really. Remember that a 30% change in mAs is required to see any kind of difference at all. You'll see a difference in your S number, but the image itself, you're not going to see any kind of difference off a 30% change in mAs. If you over or under expose the patient in the image receptor and you need to make a repeat, it's worth doubling or halving the mAs in order to make that repeat. Okay, so if an image is worth repeating, a 100% change in mAs is required. So if you need to repeat because you underexposed patient, then you need to double your mAs. If you need to repeat because you overexposed patient, you need to cut your mAs in half. The easiest thing to change is time. If you need double your exposure, then certainly you can double your time in order to make that change. But you've got to be careful that your patient can follow directions well enough that increasing the time long enough, doubling the time, doesn't introduce motion. Again, motion is the main thing that will destroy sharpness of recorded detail, and you can't fully control the motion. So that comes with it the danger of introducing motion anytime that you increase time significantly. So sometimes it's more appropriate to change your MA rather than changing your time. Increasing MA and reducing time to maintain the same mAs limits motion, and that's basically your law of reciprocity. As long as you maintain the same overall mAs value, it should not, in theory, matter if you increase your MA and decrease your time, as long as that mAs value remains the same. Likewise, if you decrease your MA and increase your time, as long as the overall mAs value remains the same, and as long as your reciprocity holds true, then your mAs value and your exposure to the image receptor remains the same. Sometimes it is totally appropriate to have a low MA with long exposure time. We talked about that before, and that is autotomo. That's where we use things like breathing technique. So you can use reciprocity to come to a low MA with an extended exposure time in order to have a breathing technique. So sometimes if you need a very drastic change in mass, then MA is your go-to, but most of the time whenever you need a change in mass that's 50% or less, it's easier to change time. So let's go back to some hypotheticals. When do we change KVP and when do we change mass? Well, we said that if we've got a change in effective Z number, that is effective atomic number, then we want to change KVP. If we want to reduce patient dose, then we might want to increase KVP. Or if we need to change the grayscale, then we might want to change KVP. But most of the time it's going to be mass. So you'll see some questions that have a combination of KVP and time, KVP, mass, or a combination of MA and time to consider. So if you have a question that says you need to maintain the same grayscale, but you need double the exposure, then what would you do? Well, that's mass. You want to maintain the same grayscale so KVP doesn't change. If you have a question that says you want to increase grayscale occurs whenever you increase KVP. So if you have a question that says I want to increase grayscale while maintaining the same exposure, you increase grayscale, you increase KVP, but you want to maintain the same image receptor exposure, you would decrease your mass. So it'd be a 15% increase in KVP with a reduction of mass. If you had a question that said that you needed to decrease grayscale means to increase contrast. So what you would do there is decrease KVP. If you want to decrease KVP and maintain the same exposure, you decrease KVP and you compensate with a double in mass. If you want to decrease grayscale and decrease exposure, then you need to decrease KVP and do nothing with mass. So sometimes it'll get a little bit more complicated. It'll say you need to, let's say, decrease grayscale and increase exposure. So now what you're going to have to do is decrease KVP by 15%. You decrease KVP by 15%, and that decreases grayscale, but it also decreases exposure. But if the question asks you to increase exposure, now you need to increase your mass. But if you double your mass, you brought it back to the same exposure. So now you need to increase your mass again. So this test should be fairly easy in the calculations. So if you have a question that says, okay, your original technique was 60 KVP at, 10 mass. You need to double the exposure to the image receptor while increasing contrast. Okay, so increased contrast means that you need to decrease KVP. So you would decrease your KVP by 15%. So you went from 60 KVP, 15% reduction would be roughly 10 KVP. So your new KVP would actually be 9, but let's say roughly 10 KVP. So now your new KVP is 50. Your original mass was 10. So if we increase our mass to 20, that maintains our exposure. But the question asked to double the exposure. So now you need to double the exposure again. So you went from 10 mass to 20. The 20 maintained exposure. Now you need 40 mass to double the exposure. Okay. So again, take the problems that may be on the test, take them one step at a time, and don't go get overwhelmed with the entirety of the question. Just take them one at a time.